Dear colleagues, ladies and gentlemen, welcome to this seminar. I want to thank Stago for inviting me and Dr. Marchetti to present our data from our laboratory in Bergamo, Italy, and for organizing this meeting all together. My first slide is just to recall that thrombosis is a frequent complication of cancer, and the manifestation include localized thrombosis, either venous or arterial thrombosis, and also systemic syndromes, including disseminated intravascular coagulation and thrombotic microangiopathies. The cancer patients are characterized, however, by abnormalities of laboratory coagulation test, and this is generally called hypercoagulable state. This hypercoagulability is characterized and is identifiable by abnormalities of laboratory test of hemostasis, that which indicate a coagulation system activation. And the results of this test show that a continuous formation and removal of fibrin is present during the development of cancer. The pathogenesis of this blood coagulation activation relies on many mechanisms, but there is a unique pathogenesis in the thrombosis activation in cancer, which is due to the nature of the tumor tissues itself. Indeed, tumor cells possess a number of procoagulant activities, including the release of the expression of procoagulant factors such as tissue factor and others, which activate blood clotting and thrombin formation. Also, they can release inflammatory cytokine and proteogenic factors, which activate the normal human blood cells, including endothelial cells, monocytes, leukocytes, and platelets. And also they express adhesion molecules by which they can directly adhere to the endothelium, platelet, and the leukocytes and form microthrombi on the vascular wall. And this process involves, of course, the production of thrombin and fibrin, and altogether the thrombin, the fibrin, the leukocytes, the platelets help the tumor cells to extravasate and move to other sites to form distant metastases. So that the coagulation system is highly involved in the dissemination and therefore in the malignant characteristics of the disease. Thrombosis can also see the first sign of an occult cancer, and indeed, since the beginning of their life, the tumor cells can exert a procoagulant effect in the microenvironment. Indeed, there are several evidences from studies in the last 10-15 years that the tumor oncogenes that drive the transformation from the normal cells into the malignant cells also drive the expression of a procoagulant factor production by tumor cells. The cancer-associated hypercoagulability not only favors thromboembolism, but also involves the proliferation and the dissemination, therefore the progression of the malignant disease. In addition, this coagulopathy worsens with the progression of the disease, and therefore there is a tight connection between the tumor burden and the clotting deregulation. So there is an interconnection between thrombosis, cancer, and blood clotting activation, saying that clotting activation enhances cancer progression and vice versa. Cancer increases the risk of thrombosis. In this setting, hemostatic biomarkers have been tested as a promising tool in predicting cancer outcomes, including overall survival, disease-specific survival, disease-free survival, progression-free survival, and tumor response therapies. In this framework is included our type of approach to the studies. Indeed, we are evaluating hemostatic biomarkers more on the side of tumor progression than on the side of thrombosis prediction. In general, the studies, the previous studies on hemostatic biomarkers and cancer outcome have been retrospective in nature and not always specifically designed to address the impact of thrombotic biomarkers on cancer outcome. In addition, where they were often mono-institutional, including a small cohort of and the heterogeneous cohorts of patients with different treatments. So there is a need for new data coming from large prospective cohorts. And for this reason, we designed this large prospective multi-center Italian study. This is an observational study funded by the Italian Association for Cancer Research, started in 2012, sorry. And it includes two different projects. Project one, in which we want to assess the capacity of thrombotic markers to predict the risk of cancer in healthy subjects. And this is a different study. And project two, in which we evaluate the capacity of thrombotic markers in patients with cancer, the capacity of thrombotic markers to predict the prognosis and venous thromboembolism. And the outcome measures are disease recurrence, disease progression, mortality, response to therapy, and of course also thrombosis. 4 types of cancers are included in the cohort: the breast cancer, lung cancer, colorectal, and gastric, because are the most frequent cancer, and they include a low risk of thrombosis cancer like breast cancer and the high risk of thrombosis like gastrointestinal cancers. Breast cancer is interesting also because it's the most common cancer in women. Is a highly heterogeneous disease with a broad range of clinical and molecular characteristics, and also variability in clinical progression. In the recent years, the information campaign and large-scale prevention screening programs have increased the rate of early prognosis and improved also the rate of patients who are treated at an early stage of the disease. In spite of that, almost 10–15% of these patients still experience local or distant recurrences in the first 5 years from diagnosis, mainly in the so-called high-risk category, which includes patients with worse prognostic factors, in which the use of adjuvant systemic chemotherapy is justified. In this category, the identification of patients at the highest risk of relapse, which means those who are relapsing very early, is important because it can improve a personalized treatment and ultimately the cancer care. In the breast cancer cohort of patients, we designed, therefore, we aimed to start some characterization of the possibility of biomarkers to predict for the outcome and the identification of high risk, very high risk patients. So we in our cohort of patients enrolled between March 2012 and December 2015, we identified patients with acute medical with who did not have acute medical illness or other exclusion criteria, but had all the data recorded properly, and after enrollment, these patients were followed up for at least 5 years. This was the cohort that we analyzed, and at each follow-up visit, clinical information on the tumor treatment and the disease relapse were recorded. Patients were categorized on the basis of subtypes according to estrogen receptor, progesterone receptor, and the histological subtypes. So we could identify 5 molecular subgroups on the basis of the histology of the tumor. And in this cohort, we could analyze 3 types of data. We have published 3 different papers from in 2001 and 2020. In the first study, which I briefly show you, we could identify that thrombotic biomarkers predict the risk of malignant disease recurrence in patients with early stage breast cancer. This paper was published in Hematologica in 2020, but online in 2019. In this prospective study, we included 701 early stage resected breast cancer patients. In this group, we wanted to evaluate whether pre-chemotherapy abnormalities of hemostatic biomarkers are associated with the breast cancer specific clinical pathological feature, and if they can predict for the disease recurrence. The hemostatic biomarkers that we evaluated were D-dimer, fibrinogen, prothrombin fragment 1+2, and factor 7A antithrombin. As you can see here, among these biomarkers, 3 of them, F1+2, D-dimer, and fibrinogen, were all elevated over normal control subject without cancer. And although the increase was not extraordinary, because I remind you that these patients were already operated, and after the operation were drawn for their blood samples before the start of adjuvant chemotherapy. The disease recurrence in 5 years was occurred in 71 patients, and as you can see here from the survival curve, we got from 2% at 1 year up to 11% at 4 years. In these slides, you can see that at the enrollment, the level of the thrombotic biomarkers evaluated were significantly different only as far as the levels of F1+2. They were more elevated in patients who had the disease recurrence compared to the group of patients with no disease recurrence, and whereas the others were not different. Also, we could appreciate that the pre-chemotherapy levels of fibrinogen were inversely associated with the time to relapse. So, by multivariate Cox regression analysis stratified for age, we evaluated the number of covariates, and among those we could conclude that tumor size, F1+2 plasma levels, and high-risk molecular weight subtypes like luminal BR2 negative and triple negative were independent risk factors for disease relapse. So this F1+2 was the only biomarker that confirmed also the multivariate analysis to be an independent risk factors for tumor disease relapse, together with the tumor size more than 5 centimeters and the histological subtypes identified as a high risk histological type. So the coefficients of each of the 3 independent covariates by the multivariate analysis were combined for the generation of a risk assessment score for disease relapse. And the DROC analysis was performed to evaluate the contribution of a score value for disease relapse. Was very good. The 2 risk groups that we could identify, we established that the cutoff value was 2.65, and on the basis of this cutoff, we identified 2 groups, low risk and high risk groups. And applying this score, we could discriminate the 2 groups with high risk and low risk. You can see that in the high risk, the risk was 20.7%, low risk 6.2%. So the 2 risks are significantly, the 2 risk groups are significantly different, and there is a more than 3 times higher risk in the high risk group than the low risk group to have a disease relapse or recurrence. So at this point, I thank you, and I stop my presentation and give the microphone to Dr. Marchetti, who will present you the rest of our studies in these breast cancer patients. Thank you.
Good afternoon to everybody. I'm very pleased to continue this presentation by showing you some data on thrombin generation in breast cancer patients in relation to early disease recurrence. First of all, I will show some data that we perform in the cohort of breast cancer patients just illustrated by Professor Falanga by performing the thrombin generation by the CAT assay. Specifically, in this study, we aim to further explore the prognostic role of tumor-associated hemostatic system impairment, as shown in the previous slides, by including the thrombin generation assay, and by restricting the analysis to the prediction of disease recurrence that occur within 2 years from surgery, so that we call the early disease recurrence. Furthermore, in this study, we tested whether thrombin generation could be integrated with previously established clinical prognostic factors in a risk prognostic model in order to improve the individual prediction for early disease recurrence. In this case, we analyzed 522 newly diagnosed patients. The thrombin generation potential was assessed by the CAT assays at 5 picomolar tissue factor plus 4 micromolar phospholipids, and plasma samples collected before starting the systemic chemotherapy. As previously said, the primary outcome was early disease recurrence, defined as either locoregional or distant metastasis occurring within 2 years from surgery. And for descriptive analysis, the patients were divided according to the primary clinical outcome: subjects with early relapse, subjects with late relapse, and subjects who remain disease-free during the whole follow-up. After a median follow-up of 3.4 years, documented disease recurrence occurred in 51 patients. Of these, 21 occur within 2 years, providing an early disease recurrence cumulative incidence of 5.6%. And the majority of recurrences were distant metastases. 68% in early disease recurrence and 75% in late disease recurrent patients. Here are the results of thrombin generation measurement in the overall cohort of patients, and then in the different group of patients that we define according to time to disease recurrence: early disease, late disease, and disease-free patients. And also compared to a group of healthy controls. As you can see, the patients display significant higher thrombin generation potential, as demonstrated by increased value of ETP, peak, velocity index, and shorter time to peak as compared to healthy controls. In addition, early disease patients had significantly higher values of both ETP and thrombin generation peak compared to disease-free patients, and also the thrombin generation peak was significantly higher in early disease patients as compared to patients that experienced a late disease recurrence. To generate a prognostic risk score for early disease recurrence, the group of patients were divided into a derivation and a validation cohort. We compared the two cohorts and we found no significant difference for any of the clinical variables and laboratory parameters, except for the distribution of the histological type. Then we perform a multivariate Cox regression analysis in the derivation cohort, starting from a full model including all laboratory and clinical pathological covariates that are here listed. And after backward elimination, the multivariate model identified the thrombin generation ETP value, the luminal B HER2 negative subtype, the triple negative subtype, and mastectomy as independent risk factors significantly associated with early disease recurrence. The coefficients provided by this multivariate analysis were then utilized for the generation of a linear score according to the following formula. The score value was obtained by multiplying the absolute value of thrombin generation ETP for 0.001 to which the 0.9 was summarized if the patient were luminal B HER2 negative, 1.1 if the patient were triple negative, or plus 0.8 if the patient underwent mastectomy. And then the risk groups were created by defining as cutoff values the 25 and 75 percentiles of this prognostic index. And in this slide, you can see the Kaplan-Meier curves according to these groups in both the derivation and the validation cohort. In the derivation cohort, the cumulative incidence in the free groups were 2.3 in the low, 10% in the intermediate, and 18% in the high risk group. A similar figure was obtained in the validation cohort with the amelioration of the low risk group, which provided a cumulative incidence of 0%. We also tried to create a nomogram for the calculation of the risk for early disease recurrence. That was more useful in the clinical setting. So in this simplified prognostic model, I can show you an example how to calculate the risk of recurrence. In this case, if we consider a patient that underwent a mastectomy, we have just the value of 2.3. If the patient is luminal B HER2 negative, we have to summarize the 2.7. Finally, we can calculate the point for ETP. For example, if the value is 2,600 nanomolar per minute, you can see here the value of 8.7. This is the sum of the score that can be interpolated in the second part, and 0.7 is equal to a 70% of risk of disease-free survival probability. Then we go further with the study with the thrombin generation, and in the same cohort of the previous study, we perform the thrombin generation by using the ST Genesia system. And as for the previous study, the primary outcome was the occurrence of early disease recurrence within 2 years from starting chemotherapy. And for descriptive analysis, the patients were divided according to the primary clinical outcome: subjects with early relapse and subjects who remained disease-free in the 2 years of follow-up. Here are the results of the thrombin generation potential measured by the ST Genesia system. The results are described, the thrombin generation assay was performed in the absence, on the left panel of this table, and both in the presence of thrombomodulin. And the results were expressed both as absolute values or normalized values for some parameters in the presence of thrombomodulin. And as you can see, the cohort of patients display a shorter time to peak and a higher ETP and peak of thrombin generation as compared to controls. Also, by the thrombin generation performed in the presence of thrombomodulin, we observe that the time to peak was shorter, and that the ETP and the peak of thrombin generation were significantly higher in the cohort of patients as compared to controls. In addition, we found that in the presence of thrombomodulin, a significant reduction of ETP and peak high were observed in both controls patients when compared to respective values obtained in the absence of thrombomodulin. But when we calculated the thrombin generation inhibition by thrombomodulin, we observed that the percentage of thrombin, of ETP and peak inhibition was significantly lower in the group of patients as compared to controls. Then we analyzed the thrombin generation parameters in the absence and presence of thrombomodulin according to early disease recurrence. So you can see the results on lag time, time to peak of thrombin generation, the peak of thrombin generation, and ETP. The data are divided in the absence and presence of thrombomodulin for each parameter, and the patients are divided in early disease recurrence compared to disease-free. So we found that lag time and time to peak were not different between patients who experienced an early disease recurrence compared to disease-free patients, while ETP and peak were significantly higher in the group of early disease recurrent patients in both in the presence and the absence of thrombomodulin. And by a univariate Cox regression analysis, we also observed that increase in ETP value was associated with higher early disease recurrence risk. Then we perform a Cox regression multivariate analysis for early disease recurrence by using both the absolute value of ETP and the normalized value of ETP. So we found that after backward selection, we identify both the ETP used as absolute value and the normalized value of ETP together with the luminal BR2 negative subtypes, triple negative subtypes, and mastectomy as independent risk factors for early disease recurrence. Here are the observations, and here the significance for each parameter we analyzed. As for the previous paper, we utilize the coefficients of the 4 variables provided by this multivariable analysis to obtain a formula for the generation of a linear risk score. So here is the ETP-based score. When use ETP as with the absolute value, or this is the score when instead of the ETP absolute value, we use the normalized ETP. We check the accuracy of each score by the ROC curve analysis, and we found that the performance of the two scores were good, as the area under the curve was 0.75 for ETP base score and 0.576 for normalized ETP base score. Then we utilize the 25-75 percentiles of the two prognostic indices to create the free risk group categories. And here are the Kaplan-Meier describing the cumulative incidence of early disease recurrence in the 3 risk group according to ETP or normalized ETP-based score. As you can see, the incidence were quite similar in the 3 group, and the differences between the high and low categories were significantly, as well as the significant between the intermediate and high risk category for both the analysis. So in this study, to conclude, by measuring the thrombin generation with this automated system, the ST-Genesia, we could confirm the role of ETP as a good potential prognostic biomarker for the prediction of early disease recurrence. We know that to corroborate this data, we need to validate our score in an independent external cohort. However, we think that the measurement of ETP through a standardized and automated system provides the basis for its use as a clinical test and supporting the clinician in the selection of patients at higher risk, deserving targeted surveillance and specific treatment strategies. I want to thank everybody for inviting Professor Falang and me to show our work on cancer patient and the hemostatic system. And this is the group of research that are very involved in the production and analysis of the data that I presented.